Um, Dr. Lewis, thank you for inviting me. And as I hoped, and it's slowly coming to shape, that this meeting is not just intervention, but the whole recognition of the vascular spectrum. And it's gradually evolving, and I've seen it evolve over the last 3 years, and I'm very happy to see that progress. Having said that, I would like to move on. Just wanted to update you about something that is more evidence-based and less exciting than opening arteries. Okay. Stroke prevention, actually, so let's first understand what kind of strokes we're dealing with. Lacunar strokes are small vessel strokes. Cardioembolic strokes, atherothrombotic strokes are related to large vessel occlusion or stenosis. And then you have this large group of cryptogenic strokes, which are now labeled as embolic strokes of unknown source. And a lot of research is going on that. And then you have subarachnoid hemorrhage and intraparenchymal hemorrhage that has shrunk dramatically from 30% to 15% now, because we understood the single factor that was driving it was hypertension, and control of hypertension actually brought it down to literally half the numbers. Just wanted to show you that people think that TIAs are transient symptoms and they would go away, and you ignore them. And stroke symptoms, of course, persist, so you come to the hospital. This is not something that's unique, that happens all over the world, and people tend to think of, like, a hand goes numb and you shake it away and it goes away. But if you look at the data, it says that the risk of having a stroke after a TIA or after a stroke is almost the same, and remains the same at 1 month, 1 year, 5 years. Here's an analysis of, which is interesting, because what it shows is that in the Kaiser Permanente group, they looked at patients who had TIAs, and they found that within 90 days, about 10.5% of patients actually end up having a stroke. And more alarming than that was the factor that half those patients had a stroke within the first 48 hours. And some of the predictors that actually suggested that you would have a stroke within the next 48 hours was older age, diabetes, onset of speech episode, weakness, or language disturbances. So these are something that we commonly see in the, and the people present with these symptoms and they've resolved, and you give them an aspirin, send them home, and end up having a stroke in the next few days. Early study in Oxfordshire actually demonstrated the fact that if you have TIA symptoms, and if you are treated like in an acute stroke clinic, or if you are sent home and on an aspirin and asked to come back in 48 hours or so to urgent clinic, versus the fact that if you are put in a stroke unit, even though you have resolution of symptoms and worked to the maximum benefit, there is an absolute risk reduction of 8.2% or 80% reduction in the probability of having a stroke. Therefore, stroke should be treated in the same way as TIAs, with the same urgency. In fact, they should be treated with the urgency that is far more than a stroke, because stroke has already happened. TIAs, you can prevent the first event from happening by a quick 24-hour workup. Some of the analyzed risk factors for larger vessel atherosclerosis are symptomatic carotid artery disease, which you all know, major strokes and minor strokes, and TIAs. We commonly advocate, and I heard somebody talking about heparin today, but the fact is that we analyze every trial that was done on low molecular weight heparin. There was no trial on heparin, by the way. The International Stroke Study was the only study that was not powered to look at heparin. But at the same time, we found that not only does heparin improve, there is no improvement in outcome, it also has no reduction in recurrent stroke rates and increases the risk of bleeding in the brain by 2 to 3 folds. So, unlike Mass General Hospital, which was nicknamed "must give heparin," nobody else in the world does. What about individualizing therapy for stroke? Stroke is not a heterogeneous thing, as Dr. Chakra just pointed out, that not everything that is venous or AVM or is same. It is heterogeneous, and so you have to individualize therapy. So we're talking about the first category, which is cardioembolic strokes. And in cardioembolic strokes, there's a risk stratification, which is called the CHAD-VAS score. And you can see the factors that go into making the CHAD-VAS: congestive heart failure, hypertension, age over 75 or 65 to 74, TIA, vascular disease, and female sex. So you add those scores, and if your numbers end up being 0 to 2, you have a lower probability of having a stroke, and therefore you should be on aspirin. And if your numbers go beyond that, then you can see the probability proportionally increases of having a stroke, and therefore you should be on warfarin, irrespective of the fact whether you had a stroke or not. There has been a lot of new drugs that have been discovered, and one of the things that we used to deal with is anybody with atrial fibrillation or cardioembolic strokes was treated with warfarin. And now we have a lot of other drugs that can be used in similar situations, but only for non-valvular atrial fibrillation. For all other situations, you only have warfarin. So, for example, valvular atrial fibrillation or low ejection fraction, etc., the only FDA-approved therapy is warfarin. The data comes from the International Stroke Trial and the European Atrial Fibrillation Trial, which demonstrated a 48% reduction over aspirin in patients with non-valvular atrial fibrillation in terms of reducing the chance of having a stroke. And that's a very, very powerful data that came up from 2 different trials, SPAV3 and European Atrial Fibrillation Trial. So that's why it's a no-brainer that you have to have Coumadin or warfarin on board if somebody has atrial fibrillation. Other drugs that have been sort of worked up in the market gradually have been focusing on thrombin inhibitors, 10A inhibitors, and direct thrombin inhibitors. And one of the first that was approved was Pradaxa or Dabigatran, which is a direct thrombin inhibitor. And for a long time it was not used because everybody was afraid that what if there's a bleed? There's no reversal agent that can be used. Now we have Praxbind, which is a reversal agent, FDA approved, for this drug, and it can be used. The advantage of these new drugs is that all of them tend to be therapeutic within a day. So it's like Lovenox. If you want to put somebody on an anticoagulant and they have non-valvular atrial fibrillation, you can put them on medication within the day, and they'll be therapeutic, unlike warfarin, which takes days before they become therapeutic. Also, just to point out that Dibigran and Apixaban are both superior to warfarin in terms of reducing stroke risk and also reducing the risk of symptomatic brain hemorrhage, the two dreaded things that you would like to address. The other advantage of these drugs is that they are weight-based, there's no diet restriction, and there's no significant drug interaction. So it's very helpful to see, I mean, most of our patients who develop a stroke are over 60, 70, and they can hardly keep track of their drugs. And these drugs are very helpful because they are BID dosing or OD dosing and weight-based. And they have nothing to do with checking the INR or multiple blood tests or avoiding food, etc., which is one of the main reasons why Coumadin is not such a great drug, because it does not allow people to remain, with this term called time in therapeutic range. So when they looked at data, most people are not in time in therapeutic range when they're handled by their primary care physicians. The time in therapeutic range is about 30%, 40%. So how do you expect warfarin to protect anyone if their time in therapeutic range is that low? Just to show you that there is a specific agent that is being developed for the 10A inhibitors, and will soon be FDA approved. So now there's no excuse for using warfarin in non-valvular atrial fibrillation in most patients, unless there's a specific patient preference. Here's something I'd like to throw out to you. So most patients who are seen with a stroke have on the MRIs at some degree of cerebral amyloid angiopathy, which goes along with dementia of the Alzheimer's type, etc. And you can see that, you can see those things. They're cortically based, and they are the commonest reason for non-hypertensive to bleed in the elderly. Work from MGH has shown that patients who have significant amount of cerebral amyloid angiopathy and atrial fibrillation, and if you put them on medication, like warfarin or any other anticoagulation, then there's a good chance that they might end up having an intracerebral hemorrhage. So now you have this population which is older, which has atrial fibrillation, and on MRI demonstrates this picture. So what do you do? Fortunately, there's another option, which is called the Watchman device, and it's just an occluder that's put in the left atrial auricle, and that's where most of the clots form. And in a head-to-head study with warfarin, it was proved to be non-inferior to warfarin. So more and more, we are sort of tending to see this kind of pattern on MRI, and when we see this pattern on MRI, we get these patients to be on the Watchman device rather than be on anticoagulation. They just have to be on anticoagulation for 6 weeks, but that's okay. I mean, that's a very short period rather than exposing to a lifelong risk of anticoagulation. Okay. Okay, we talked about, what about non-cardioembolic strokes, okay? So you have the warfarin aspirin recurrent stroke study, which showed that there was no difference between warfarin and aspirin in non-cardioembolic strokes. So there is no absolute no use of warfarin in non-cardioembolic strokes. Aspirin, now we're moving to antiplatelet drugs, the standard therapy. There's no reason to use high-dose aspirin because 81 milligrams of aspirin is as good as anything else. It's been shown by two meta-analysis trials. It's important just to point out to show you that for clopidogrel, which is used very often in stent trials and other studies, the study was positive only for peripheral arterial disease. It did not do anything for stroke or anything else. Finally, for dual antiplatelet therapy, for established stroke, there's absolutely no role because in the MASH trial, it doubled the risk of bleeding and did not improve outcome. Similarly, in the Charisma trial, which was, again, dual antiplatelet therapy versus aspirin, there was no difference in outcome and double the risk of bleeding. All right? So then the Agrinox or extended-release dipyridamole was marketed and actually showed a very positive role for extended-release dipyridamole over either aspirin or extended-release dipyridamole alone, both in vascular terms and in terms of prevention of stroke. And ultimately, what I was pointing out in the morning was this PROFESS trial or the head-to-head trial, which actually shows whether these things are real or not. And in the PROFESS trial, there was no difference between the outcomes with Agrinox or versus Plavix. And there was no difference in ARB inhibitor and placebo. So how do you rationalize therapy for antiplatelet drugs? You give clopidogrel 2 milligrams, if there's peripheral arterial disease, which is what drove the Capri trial, then you should consider clopidogrel. If it's a first stroke, aspirin, and if it's a first stroke, you can also choose Agrinox, because it is definitely a superior drug compared to aspirin alone. Any place for dual antiplatelet therapy? Stents 3 months to 1 year, and cardiac stents is different, but in coronary stents, it could be as low as 6 months, 6 weeks, sorry. Also, there's an ongoing trial in here, which is on TIAs, which is looking at dual antiplatelet therapy versus aspirin alone. And the trial is, I'm not sure when it'll finish, but it's ongoing. And we'll know whether the right thing to do is to treat patients with dual antiplatelet therapy for 3 months, or just treat them with aspirin alone. Okay. For blood pressure control, the goal is 140 over 90 millimeters of mercury or less. And the two drugs that have shown efficacy beyond and above the blood-lowering ability have been these two drugs. And in Progress and Hope, Ramipril and Prindapil both reduce stroke and cardiovascular risk significantly. What about statins? The standard is to use high-dose statins in every case of acute stroke. So the dose that we use is 80 milligrams of statins in every case, unless contraindicated. And also the Jupiter trial has shown that if C-reactive protein is high, irrespective of statins, you should use high-dose statins. So, and again, it improves outcome. We had the first paper that showed that. And subsequently, this paper by Flint et al. Showed that you should give high-dose statins in the first 48 hours after in the acute onset, because subsequently the effect is not as powerful as before. So, having said that, it also reduces death rate, it improves outcome, and there's absolutely no reason not to use high-dose statins in the first 48 hours. You don't have to wait for an LDL. It doesn't matter what the LDL is. And the reason for that is these pleiotropic effects of statins, which are far beyond just the lipid-lowering effect. Okay, that's moving on to the newer lipid-lowering drugs, which are Pcsk inhibitors. Because a lot of people are refractory to statins or not, do not have lipid-lowering effects that are good. The Pcsk inhibitors actually bind to LDL receptors and improve lowering of LDL by 60% on top of statins. Finally, just talking about surgical management. So NACIT, of course, showed that there was a great improvement of CEA over aspirin. And asymptomatic carotid artery stenosis should not be treated because nobody can achieve the mortality and morbidity that they achieved in the trial of 3%. And nobody does actually treat this. Sapphire was the first trial that showed that stenting, carotid stenting, was as good as CEA. And then finally, CREST demonstrated, interestingly enough, that older patients should always have a CEA, and younger patients do better with stenting. So, what about intracranial stenosis, which is a big issue? Stenting, the SAMPLES trial actually demonstrated that the best medical management is better than putting a stent in. Patients did much worse with stenting as compared to the best medical management, which means high-dose statins, control of blood pressure, and dual antiplatelet therapy for 3 months. So this is what you can achieve by prevention instead of dealing with just the failure of prevention, which comes down to about 14% of all stroke patients, where intervention is required, costing millions of dollars. So, simple things, but very important. As I told you in the beginning, they're not exciting, but they are important and they make a difference, far more than any vascular intervention can. And finally, if somebody has sleep apnea, address it, because it's one of the most under-recognized causes of stroke. Okay, that's it. Thank you.
Do you have any questions? Okay. Thank you, Professor